Good evening, everyone, and welcome once again to DTech Dialogues. So excited to be back after a short interlude of 3 months and back with a fantastic lineup of not just internationally known, but also nationally very well known, the DTech Founders Group itself for the webinar today. Without much ado, may I welcome all of you to DTech Dialogues and also our experts today for a fantastic academic feast. And with that, I would love to have Dr. Banshi Sabu sir, who is our DTech Founders President, and also for him to welcome us all and also share his thoughts on DTech and DTech Dialogues uh, with all of us before DTechCon 2026 preparations begin.
Thank you, Purvi, for this wonderful initiative. And I must congratulate everyone who is involved here in this DTech dialogue, which we have started. As we know that technology awareness and uses of technology to be increased in our country. And I always remember Jyoti's word that it is only technology which can really change the care for diabetic patients. I mean, we are working for type 1 diabetic patients since last so many years, 25 years, and it was AID. The first time we could see our patients with AID to achieve time in range for more than 90%. Even some of the patients, for some days, it is 100% of the time they are in time in range. First time I've seen people with HbA1c of less than 6, as someone who is type 1 and is achieving his HbA1c. Now, we stopped doing their A1c, but it was in initial phase of some patients, when their HbA1c was more than 9, 8. So technology really can change the way we are treating our patients. The same way continuous glucose monitoring, what I used to treat my patients before 5 years, 10 years, before doing their continuous glucose monitoring, and how we used to adjust the doses of the medication, because we are users of sulfonylurea, we are users of multiple combinations, we are using premix, we are using co-formulation, and that everything is changed the way we are treating our diabetic patient after seeing their continuous glucose monitoring. So these technology uses in our country had really changed the way we are treating diabetic patients, and particularly those who are DTech founders, they are high users of these technology in our country. Even the electronic medical record system, I can say proudly that after I become the part of some of the international registry and using electronic medical record system of my own and seeing them again and again, I have seen improvement in care, improvement in my practice, improvement in the patient's care, what we are doing. So I think technology usage should be increased in our country, and this is the initiative of DTech. We are regularly partnered with international like ATTD, which is the Advanced Technology and Therapeutics in Diabetes, which they are doing meeting in Europe and Asia. We are also, since last 4 years, doing a diabetes technology meeting in India. I'm very fortunate that we have co-founders and friends like Jyoti, Rakesh, Manoj, Mithun, Amit, Purvi, who all are the part of it. And this year, and we are going to do DTech in Mumbai, we all are very excited, and I'm sure we will have thousands plus doctors who are really interested in diabetes technology. We are also thanking industry partners who are now, many companies have come in India with continuous glucose monitoring. We are also happy to have even Eversense have come, which is like a long-term continuous glucose monitoring you can put, and it is just subcutaneously insert the sensor. So all these things are available. We are looking for many new companies who will come with a insulin pump, AID, even Dexcom, and many more companies. We all are very excited. So next year it will be really big. And all our diabetes conferences, whether they are technology company are participating or not participating, but we always see that it revolves around technology. Our scientific program revolves around the technology. And that is what we have seen that change after DTech when we have started. This year at Jyoti JPF, a very large meeting which is doing, very big meeting which is doing this year, Liberate 2 had come to. So we are excited that, they are announcing their new product with our national meeting, with our diabetes technology meeting. We have launched in our DTech also many new technology in India. Even a one CGM company have introduced their CGM through our company. This year also, online one more UK-based company had launched that at Jaipur meeting. So we are thanking Rakesh for a wonderful meeting which he has done, and congratulations to Manoj and Purvi. And in advance, I am saying a congratulations, but all the best for DTech 2026. With this, I request to start again because already we are getting late, and we will finish your questions first. And I'm sure Purvi will invite you for next, meeting. It will not be online. Ellen will be in India for doing even DTech dialogue also. Thank you.
Thank you for those very wise words and a very upbeat note on technology use in India. I think it's improving every day, and DTech Dialogues definitely helps in training more and more physicians and attuning them to the use of simple measures like CGM and even artificial intelligence and many other aspects of technology. So without much ado, let me welcome our international speaker today, Dr. Elaine Shao from Hong Kong. She is a clinical associate professor in the Department of Medicine and Therapeutics and deputy medical director in the Phase 1 Clinical Trial Center at the Chinese University of Hong Kong in Hong Kong. She received her medical training in UK and completed her PhD on cardiovascular effects of hypoglycemia and type 2 diabetes. She joined the Chinese University of Hong Kong in 2015, where she set up the glucose clamp and sensor evaluation studies at the Phase 1 Clinical Trial Center and secured a number of external grants, and currently is also leading clinical trials on use of CGM in pre-diabetes, advanced chronic kidney disease, and peritoneal dialysis. In particular, she's interested in the evaluation of insulins, GLP-1 receptor agonists, as well as other drug as well as non-drug interventions for cardiorenal metabolic disorders. And she has led as an investigator and co-investigator in so many different clinical trials. She's very well published internationally, and she has received several awards, including the Hong Kong College of Physicians Sir David Todd Lecture in 2024, the HKCP Richard Yu Lecture, and Women's Interprofessional Network of the American Diabetes Association Abstract Award in 2022. And in addition to teaching and research, she's also the associate editor for Diabetes Research Clinical Practice and on the editorial board for several journals of repute. Welcome, Dr. Elaine Chow, and we can't wait to hear your thoughts on the CGM in advanced chronic kidney disease. And of course, personally, a big thank you to you for staying up so late. You're live here, and it's beyond 10 p.m. in Hong Kong. So thank you again from all of us.
Thank you very much, Purvi. Thank you, Dr. Banshi. It's really my privilege and honor to be here. And I just, so inspired by your words. I really think that diabetes technology, as I've seen it in the last 5 to 10 years, has really transformed the lives of so many people. And today, I'm very glad to be able to speak about a topic which is very close to my heart. I think it's a very area of very high unmet need in Asia. I'm sure you probably would see a lot of people with diabetes and advanced CKD in India and many parts of Asia. And I hope I could share with you today some of my experience and perspectives of use of CGM and other glucose monitoring technologies in this population. So this is just my disclosures. So in the next half an hour or so, I'd like to share with you some of the current evidence outlining some of the unmet needs for glycemic assessment in people with diabetes and advanced CKD. So, we know that A1C and fructosamine are unreliable, and these patients are, very prone to both hypo and hyperglycemic excursions. I mean, I think we'll try to address this question, if these CGMs are accurate enough in CKD populations and how they can be used as glucose management tools in these patients with end-stage kidney disease or on dialysis. So, I mean, diabetes is still a major cause of CKD, accounts for 50% of kidney failure in the developed world. In Hong Kong, we see a very high prevalence of kidney failure based on data from our renal registry. And in particular, we see a very, very worrying trend of young onset diabetes. So people having type 2 youth onset, usually below the age of 40. And if they have the disease starting from their, late teens to 20s, they often develop to serious kidney disease leading to dialysis, even in the early 40s and 50s. And this is a very, very depressing fact. And even in the US renal register, although there has been a decrease in other complications, kidney disease still remains one of the very top complications that are seen in that part of the world. So, I mean, we have observational data to suggest that, if we are able to control the glucose better, this may delay the progress of chronic kidney disease. And these are based on observational studies. And currently, the KDIGO recommends an optimal A1C target of between 6.5% to 8% for people with CKD. But obviously, with some caveats of thinking about the individual's age, life expectancy, and the resources to manage their glucose. So why are patients with CKD so difficult to manage in terms of their glucose? There are multiple risk factors for both hypo and hyperglycemia. So we think about the hypoglycemic end. I mean, most of these patients have long disease duration and they often are already beta cell deficient. But obviously, there are also a decrease in the insulin degradation and also the hepatic clearance of insulin that maybe we will predispose to a hypoglycemia. It's well known that there is a decrease in the renal gluconeogenesis, and also other factors such as uremic toxin accumulation may also increase the risk of hypoglycemia. On the other end of the spectrum, they are also vulnerable to hyperglycemic excursions, particularly in the more advanced stages because the uremic toxins create an insulin-resistant state. But also, there is a hypoglycemic load introduced by use of glucose-containing diazolates, particularly in peritoneal dialysis. And also we're thinking about other factors such as dietary factors, and many of these people often have a reduced appetite due to uremia and toxin accumulation. So I think this makes the whole picture very, very complex. And of course, the other major considering factor is that many of the CKD the drugs cannot be used in people with advanced CKD. So I mean, with metformin, usually we will have to reduce the dose when you reach the eGFR of below 45, and I mean most people would stop the metformin once the eGFR reaches below 30. And I mean, personally, I see this creates a huge range of problems because you lose the insulin sensitizing effect, and the only thing you could put these people on an insulin, and often complex regimens with multiple daily injections, which is really the main safe option up until hemodialysis. I think now we have a few more options, such as using a renal dose DPP-4 inhibitor and some GLP-1 receptor agonists, and that are some agents that we can also consider in the advanced CKD stages. So, but however, I mean, most of the patients, I mean, I look after, I see them from the whole spectrum from, when they start into reaching the CKD stages 3 and 4. Generally, you would see they usually have a decrease in insulin demand and generally decreasing in glucose levels as they reach out more what we call burnout diabetes. But then once they hit the CKD stage 5 and they go on dialysis, then again, depending on what kind of dialysis they go on, they can have a whole different pattern of, glycemic management, which is extremely, extremely challenging. So, I mean, how well are patients with end-stage kidney disease managed in terms of their glucose? So this is a very nice paper just published in JASN by Ian DeBoer and colleagues. And they looked at a very large cohort of 420 patients on dialysis. Some of them are using parenteral dialysis, some of them are on treatment, and some of them are not. But if you look at the patients who are on treatment, that is some glucose-lowering drugs, you'd be very depressed to know that only 43% of them are reaching the mean time in range is only 43%, and only 22% are achieving a time in range over 70%. And you could see there is a very, very high event rate for hypoglycemic events. And this is actually quite distressing to know. And what are the kind of patterns that we see in patients on hemodialysis? So I think this whole phenomenon called what we call glycemic disarray was first described by some people in a group in Japan. So what you see is during the hemodialysis period, there is a removal of the glucose and insulin during the hemodialysis, and quite often people get low glucose or even hypoglycemia whilst they're having the hemodialysis. But actually, after the post-HD, you can get some kind of a hypoglycemic surge overnight. This is an example of a real patient that we were looking after, a type 2 patient, using glucose-free diazolates and just on some glargine, insulin, and allogliptin with A1C 8.2%. But this kind of trend, it's actually very, very, very difficult to manage. What about people on peritoneal dialysis? So in Hong Kong, we have a PD first policy. So this is the bulk of our patients, maybe 70% of them are mainly on sort of CAPD. So for example, this is a patient, a 57-year-old patient who's type 2 diabetes. So he is on sort of 3 bags of 1.5% dextrose PD exchange a day. And you could see that he's also on a multiple daily injection regimen of insulin. So, he's taking glargine with 44 units as a basal, but then by and large, we're still mainly giving the insulin aspart, the quick acting alongside the meals. But you have to remember these patients are not only getting glucose surges from what they eat, but more predominantly from the dextrose containing diazolates. And you could see it's actually quite difficult to manage these surges. So next, I want to discuss is, so one of the biggest challenges is the accurate glycemic assessment in people with advanced CKD. So, it's fairly well known that HbA1c is less reliable in people with advanced CKD. And this is for multiple reasons. So basically, the main reason is because of alterations in the red cell turnover and the glycation. So, as you probably all know, in people with advanced CKD, they quite often have anemia, and often they have to use erythropoietin stimulating agents or ESA, and this it will increase the red cell turnover and actually would bias the HbA1c low. But however, at the same time, these patients are also quite vulnerable to developing iron deficiency. And then when there's a state of reduced red cell turnover, this actually might also bias high the HbA1c. Also, there are other factors that can, affect the HbA1c. For example, metabolic acidosis and also the carbamylation, which people see in advanced CKD, can also bias high the A1c. So what about other markers? So, for example, we could also use other, the fructosamine or glycated albumin. But this also has a similar problem, especially in people with DKD who are typically quite, heavily proteinuria. And actually, in this kind of state, this may be biased low. And this is there's some observational studies. If you look at the correlation between fructosamine and fasting glucose, you could see the correlation actually also decreases as your CKD stages progress. So I think, this kind of highlights that we really need an alternative means of glycemic assessment that are less biased by CKD and these, these various factors. So this is a study we published a few years ago. So this is in patients who are in diabetes, CKD stages G3B to 5 who are not on dialysis. And we looked at the correlation between the measured HbA1c against the CGM-derived glucose management index. And you could see that as your CKD stages progress from stages 3B, 4 to 5, the correlation between the A1C and GMI generally decreases. And it's only, really very weak when you reach a state, even in a non-dialysis stage G5. So I just wanted to share with you a real case of a patient we looked after. So this is Mr. C. He's 66-year-old. So he's had type 2 diabetes since he was 47, already had diabetic nephropathy for a number of years. He's already known to have fairly brittle diabetes, and he is on a multiple daily injection regimen of insulin. So, he is actually attending a hemodialysis at a community center on Monday, Wednesdays, and Fridays. So he usually has a 12 to 6 p.m. session. And because of his, difficult to manage diabetes and where he lives, he's actually co-managed by both the renal and diabetes teams. So I mainly sort of look after him from the glucose and monitoring perspective. So anyway, so this was him in December 2024. So we still took some lab tests. The HbA1c was 10%, his urea was 15, and his hemoglobin was about 9 grams per deciliter. So he was a little bit on the anemic side. And we asked him when he do his SMBG. So he only does it on his hemodialysis days. And he roughly reports that his pre-breakfast one is about 9.5. In the post-dinner, it tends to run a bit high, especially after his hemodialysis. So it runs between 13 to 80 millimoles. And sometimes he takes extra snacks during his dialysis because he feels a bit hungry. So based on these readings, I increased the glargine, to 18 units in the morning, and then I thought, okay, let's maybe increase the dinner aspart a little bit more to maybe 10 units. So what happened in a few months down the line? So again, I saw him back in February this year. So actually, he developed symptomatic anemia. So his hemoglobin was down to 6.5, and you could see his MCV was low. Only I think it used to be about 75, and it was progressively dropping down to 67. And the renal physicians increased his ESA, the darbepoetin frequency, because he thought the HB was dropping. But also, the renal clinicians recognized that, because of the low MCV, probably he has also got iron deficiency. So he was given IV iron, so they're given the IV Monifer. So because he was quite symptomatic, he was also given some blood transfusion. And so, when I saw him in clinic, actually his HbA1c was 10.6%. Yet, the renal clinicians are saying, okay, so it does sound like his glycemic control is not so brilliant. But I had very few SMBGs to go by. So therefore, just based on this limited information, I further increased both his basal and also his pre-meal insulin. However, the patient actually agreed to have a blinded CGM for insulin titration, and so that's what we did. So so this is his 14-day blinded CGM. So actually, this was paints a very different picture. So the glucose management indicator was only about 7.5%, and if you look at the time in range, only 50% was within the 3.9 to 10, 12% was in the time below range, and about 38% was in the high range. And if you look at this whole distribution, you could see the variability is extremely high. So you have, experiencing, lows in the evening, but also, high excursions in the later morning to afternoon. And also with this daily graph, you could see this very big swings. I mean, you like to think these swings correlate very well with his HD days, but in fact, they don't. But this is, the kind of patterns that we were seeing. So anyway, so actually we saw him quite quickly back in March. But so we actually took the blood test just a few weeks later. But you can see the HbA1c was actually 8.7%. It was down. But again, this is quite difficult to interpret because he had so much of the ESA and iron replacement, which could actually bias it higher or low. But by this time, at least his hemoglobin was up and his MCV was back up. We got him to see our diabetes nurse educator, and we found that he had lipohypertrophy in multiple areas of his abdomen. And also based on the CGM, we actually adjusted the insulin. So we at certain points we thought, okay, maybe after correcting his injection technique, we didn't need such a high dose. So in fact, actually we down titrated some of the insulin as well. So this patient, again, we saw him after a few months' time, and he, in fact, I think he was self-bought one of the ICANN CGMs himself to help his self-monitoring. So you could see actually his time in range improved. It was now up to 76%. His time below range was only 2%, and the GMI was 6.9% with a CV of 37%. So he seems to be doing a lot better. So, currently the KDIGO 2020 guidelines, they do recommend the use of CGM and particularly use of GMI in patients in stages G4 and G5, including patients on dialysis or transplant. And this is, where the A1C is particularly, less reliable. So, however, what about the accuracy of CGM in advanced CKD and ESKD? So, why are there different considerations? So, as you probably all know, most of the commercial sensors are based on sort of glucose oxidase, there are potential enzymatic and electrochemical interference by some of these substances that are commonly encountered in people with CKD. So, for example, the urea and the hyperoxia can sometimes influence the accuracy of can cause interference with the glucose oxidase enzymes. For example, some metabolites of icodextrin and such as maltose, we know that can interfere with the GDH-PQQ glucometers due to the lack of selectivity on glucose. So, there are a number of studies in the past few years where the people have been specifically examining the accuracy of the CGM in people on dialysis. So this is a paper, very nice paper by Narasaki and colleagues. So they were looking at the CGM in people with maintenance HD, and they were looking at the correlation of the Dexcom G6 against the point of care devices. And if you look at the overall mean ARD, so it's only actually about 5%, which is probably higher than usually what was seen in the non-dialysis population. And the percentage 2020 agreement is actually also on the lower side. So this is another study done in UK, the Alpha 2. So this was looking at the G7 sensor. But a very small study, only in 10 adults. Again, people on hemodialysis. This was against a laboratory measured a gold standard, the EKF analyzer, venous glucose. And in this study, they found the MARD was about 10.4%, and most of the values were within an acceptable range in the decision error grid. So, we in Hong Kong, because we do a more PD, so we also did this study. This is with the Medtronic Guardian Sensor 3. So this was a study where we compared the CGM glucose against the YSI with glucose challenges across different glycemic range. So in this study, we found the MARD actually was lower. So it was 10.4%, which is maybe not too different from maybe the non-dialysis population. And about 99.9% of readings were in the consensus error grid zones A and B. So in this study, we also considered whether, for example, some fluid status, such as people, if they were fluid overloaded, whether they would also influence the accuracy of the CGM sensor. But based on all these measurements of body water and hydration status, we saw no correlation between these and the MARD, and also very little influence of the hemoglobin or hematocrit. So, I often get asked the question, so can these commercial CGMs be used in people with patients on dialysis? And the official answer from most of the major ones, so some of them explicitly say, for example, Freestyle Libre 3 has not been evaluated by people on dialysis. And also, for example, the Dexcom, it does specifically say that do not use in dialysis. However, the trends I see in Hong Kong, even with this advice, most patients are using it off-label. I think there may be a role of using CGM as kind of a blinded CGM for retrospective, treatment adjustment or for research. I think it's still useful for reviewing glycemic trends, but if people were really to use it for treatment decisions, I generally would still advise them to be sort of using it adjunctively with SMBG. Okay. So finally, what about using CGM really as a tool for glucose management in people with advanced kidney disease? So, sadly, actually, there is currently a lack of evidence. So, so far, most of these studies were very small and they're not randomized and usually single-centered. And I think this reflects because these populations are very challenging to study because they have very, complex and comorbidities. I think there's also, a difference between different sensors, and most of these studies tend to be quite short in duration, and the optimal duration of sensor use is actually unknown. And what we still really need is studies which provide very hard clinical and patient-reported outcomes. However, we recently did complete a study. So this was looking at GLP-1 receptor agonists. So this is the weekly dulaglutide with basal insulin versus just basal bolus insulin on, looking at CGM metrics of glycemic variability and time in range in people with type 2 diabetes and advanced CKD. So this was an academic study that we performed in Hong Kong. So a 26-week open-labeled parallel group RCT. So we recruited about 95 patients with a mean age of 65 years, disease duration about 20 years. And we randomized them one-to-one either to the BGLB group. So basically, they were given degludec once daily with dulaglutide 1.5 mg once weekly versus the basal bolus regimen, which is kind of still the default, which what people are mostly on. So this is usually, insulin degludec, a second-generation analog with, 2 or more rapid-acting analog injections. So this is a study we designed here. So basically, in the first 16 weeks, we titrated the treatment just using routine BGMs, and then we performed blinded CGM at baseline and also week 16. But actually, we did an extension phase where in the last 10 weeks, between week 16 to 26, we gave both groups a open CGM. So this was Dexcom G6 in open mode, and to see whether, in both groups, they would derive similar benefit from the open CGM use. So, we recruited patients with type 2 diabetes who were in CKD stages 3 to 4 with the A1C between 6.5 to 9% at screening. So these results we just presented at the ADA in Chicago. So actually, maybe not unexpected, we found that both the time in range and percentage CV was in favor of the group who were using the weekly GLP-1. So the glycemic variability was lower in the BGLP group, and also the time in range was 9.6% higher in the people who received the GLP arm compared with basal bolus insulin. But also, if you could see that between week 16 to 26, we didn't actually change their drug treatments at all. We purely gave them a CGM. But you could see that, even in the BGLP group, there was an increase in the time in range by a further 3.7%. Whereas in the basal bolus group, there was an improvement in time in range by nearly sort of 6.3% in just with 10 weeks of CGM. And throughout the whole study, the time below range was very, very low. And what about if we think one step further, use of maybe automated insulin delivery? Because as you see, people on the hemodialysis could have very, very fluctuant glucose profiles. So this was a study by Charlotte Burton in Cambridge. This was a study in 26 adults on hemodialysis. And they were comparing two periods where one, they were using the Cambridge closed loop system with this the Dexcom and Dana pump, and then in the other period they were in the control arm where they were just using the standard insulin therapy with CGM. And you can see in this very, very nice graph here that, in the closed loop group, the time and the target glucose range, which they set to between 5.6 to 10, this was, 52% versus 37% in the control, with a 15% difference better in the closed loop group. So this is very, very promising to show how, in a use of, AID systems could potentially really transform the management of people on these complex dialysis regimens. So just my final thoughts and conclusions. So, I think, people with diabetes and advanced CKD are very heterogeneous and a complex group. They're dealing with both hyper and hypoglycemic excursions. And you could see they have very, multiple factors such as differences in physiology, treatment, dialysis mortalities, dietary factors. And currently using A1C alone is a highly unreliable glycemic marker. It can be biased high or low, and I think there's generally no way to guess which way the way it affects the direction. I definitely think that potentially CGM is useful as a tool to guide glycemic management. However, currently there's still a very lack of studies, one on sensor accuracy and also on clinical and patient-reported outcomes, despite I see a growing number of patients who are actually needing these devices. So I hope I could inspire people in the community to do more research, looking at the safety, efficacy, the optimal frequency, and also what we can do in terms of diabetes technologies for this very challenging patient group. So I would just like to end by thanking my team. So James Ling is, my former PhD student, now my postdoc, who did most of this work, and also our brilliant team of diabetes research nurses at the Chinese University, Hong Kong. So I would like to thank our renal collaborators at CUHK, so Professor Sito, Dr. Jack and Dr. Yun, and also to our funders and to our whole team. So I would welcome any comments or questions you may have. Thank you.
Wow, that was a fantastic talk, Dr. Elaine, and thank you so much. If you can, speak like this at beyond 10 p.m., I just want our audience to be well aware of what you will do during the day. Thank you for that fascinating talk.
Yeah.
Brilliant. If I can add, Dr. Elaine, it was just so wonderful listening to your talk on this particular topic. It really is getting us up to date on what's happening with the use of technology in the DKD front. So thank you so much for that update and taking up this time relevant to India and staying up back home in Hong Kong. Thank you so much on behalf of the entire DTech group and the founders here that you can see, Dr. Jyoti Dev, Dr. Mithun Bhartiya, Dr. Rakesh Parekh, Dr. Amit Gupta, and of course, Dr. Banshi Sabu. And many thanks to Dr. Purvi, who's been coordinating this with you and the entire group. Thank you so much for these words of wisdom and joining in.
Thank you.
We're not done just yet. I do have a couple of questions, and I think your presentation was so complete that you did touch upon all these points, but let me just begin with that, and I'll request the group to chime in. So, you did mention in your conclusion slide, and I noticed that, there are no hard outcomes even now with CGM use in advanced CKD.
Yeah.
So do we have a sense whether it is reducing hospitalizations or not really conclusive at all?
No, I think a very important question. I think so. First of all, I also see a very high number of emergency admissions to a hospital for both hyperglycemic and hypoglycemic emergencies, and that most of it originates from in the unreliable glycemic assessments based on A1C. So I think, I think I could cite a paper from Diabetes Care that was published by, I think, Rodolphe Galindo a few years back, where they highlight, the sheer number of hospitalizations. And I'm sure this may be similar to other parts of the world. So I believe that at least for one, like that patient I presented, it could have so easily been mismanaged if we solely just based on the A1C. So I think one, we could reduce the hospitalizations purely due to these glycemic emergencies. Now, the second and third bits about hard outcomes. I think we recognize these people are very, they have, multiple comorbidities. But for example, people on peritoneal dialysis, one of the most common reasons for admissions or death may be due to infections. So particularly, the PD site infections, and that must somewhat relate to the glycemic control. So I think we still need to do those studies to see whether they can also reduce that kind of outcome. Whereas in the people hemodialysis, and also I think recently I've seen some nice work from Denmark. So looking at the glycemic excursions, which can also be linked to maybe sudden arrhythmias or cardiac death. So again, I think be able to control these excursions might also reduce other types of cardiovascular events possibly. But I think there's so much work that still needs to be done.
Absolutely, that makes sense. I think that also brings me to another sub question that, what about the use of CGM in hospitalized patients themselves?
Yeah.
So,
Very good question. So, I think in general terms, the CGM, whether this is good enough to be used in hospitalized settings, because I described some of the potential interferences, and which, when people are acutely ill, so the hypoxia, will affect your glucose oxidase sensors. Most of them may be even more acidotic. So again, this could potentially influence sensor accuracy. So, if we're not even sure that it's accurate enough in people with end-stage kidney disease, I think even the hospitalization state, it's probably difficult to use as a sole measure for glucose without some SMBG. However, I've been so encouraged to do that, in fact, because I have looked after so many patients on the ward where we've been absolutely struggling to titrate the insulin. So yeah, I think that again, we need to think about how to use these sensors, and maybe we need, just because these patients are, we are and they're not large enough numbers in any single center, so we just probably need to do more joint work. Yeah.
Great. The group is chiming in. I'll request Dr. Jyoti sir and then Dr.
Oh, yeah. Oh, yeah. Thank you. Yeah. Okay.
Yeah. Thank you, Purvi. Your lecture was very good, fantastic, and a lot of learning, and it was very comprehensive. Congratulations again to Elaine. So my question is, there are a lot of limitations using continuous glucose monitoring in people on dialysis.
Yeah.
In peritoneal dialysis, there can be hyperglycemia. In hemodialysis, there can be hyperglycemia.
Yeah.
So my question is, CGM is anyway very useful, highly beneficial in people who are having advanced chronic kidney disease, and this is especially to prevent hyperglycemia. So anyway, technology is growing. And are you aware of any CGM studies currently ongoing, or are you aware of any new continuous glucose monitoring devices being tested in people with advanced chronic kidney disease?
Yeah. So as I say, we've been doing some work with some of the sensors, a couple of studies in Hong Kong where we tend to have work more on PD. I'm sure there are international groups that are working on that, but in terms of specific sensors for people with SHTD disease, probably not at this moment in time, as far as I'm aware. I think there are a number of studies looking at use of AID systems in people on dialysis. But I mean, I think sensor accuracy is one thing, but also the complex needs of these people who, because they have kidney disease, they also often have a visual impairment, right? And that is a huge challenge. And I think I didn't have time to touch on is the usability of these devices. I struggled in my 2 clinical research studies to get these people to use them simply because, they often had, they were dealing with already dialysis, right? So they're having to do their PDs or go to HD, and it's an added burden for them to use additional devices. So something also we need to think about a simplicity issue and also skin issues as well, because you think about the uremia, right? So they're often itching already, and we need to think about sensors which fit them well. So yeah, so I think, I agree with you. It's a very important thing to address. Yeah.
Thank you.
Yeah.
So Elaine, excellent talk. I wanted to ask a question. Blinded versus unblinded CGM,
Yes.
because the behavior may change if it's unblinded.
Exactly.
So your views of that.
Yeah. So I think, thank you for bringing this up. I really like to discuss this because personally, if you look at some of the studies which have been published, right? So I think quite a few have been done on just blinded CGMs, and one of this obviously a consideration because none of them are officially approved for use in dialysis, right, for real-time decision making. Personally, as I fully agree with you, we put a sensor, a real-time one, on someone for like a few days and immediately change the behavior. So I think, we probably, if you're purely using the CGM for glycemic assessment, I think a blinded one's enough. And almost think that, if you're purely wanting to an alternative marker to A1C, the blinded one for maybe 10 or 14 days is probably enough to give you a rough idea what's going. But I think in those people who have suboptimal control, once you identify those trends and they need the extra bit, the tools to give them the hyper and hypo alerts, and then you probably need to think about using it as a real-time tool. Yeah, so a very good question.
Yeah, I would agree on that because it'd be very difficult to do a study on unblinded.
Well, yeah, I know, but I think in this kind of space, I mean, I see that my patients are already doing it quicker than I am, and I think I've seen a lot of patients because they're using the CGM in the advanced CKD stages before they get to dialysis, and they're just carrying on using it. So I think also our nephrologists are now getting more and more familiar with these technology, and also thanks to your many of these educational activities with whether it's DTech or other organizations. So I think it's I think increasing tech use really also we need to involve other professionals as well. So
how did you convince a nephrologist to be part of it?
It's work in progress. That they're already engaging. So I think co-care as well. So yeah, I think we need to think about how to. They are also, a lot of them are now increasingly using CGM as a tool. So yeah.
So it's interesting. There are actually publications with suggesting use of what the nephrologists need to know about CGM.
Oh yeah, they do. Yeah, but I think also, I mean, I think again, what to do with the profiles is challenging because as you say, so many factors that are interplaying, and whether whether our current insulins, which is the best way or time to give it. I think there's still a lot of unanswered questions that we need to think about too. Great.
So I think if we don't have any more questions, and we can always email Dr. Elaine. She's an email or a phone, WhatsApp away. I think if we are done, we can allow her to log off because it's already pretty late in Hong Kong.
No.
So
thank you so much, and hope to see you again also.
Thank you.
Okay. Thank you. Bye-bye.
Wonderful. And once again, thank you so much.
Okay. Thank you. Bye.
Bye. We move on now to, from very advanced CKD use of CGM, going back to basics What about CGM use at therapy initiation itself? I think that's again something that physicians struggle with. And for a very simple take on CGM at therapy initiation, because we have all the guidelines and we have all these, set of consensus, but what exactly do we do in the clinic? So let's hear it from our next speaker, Dr. Manoj Chawla. He's a consultant diabetologist and director at Lena Diabetes Care and Mumbai Diabetes Research Center. Also consultant diabetologist at Hinduja, Fortis, Raheja, and BSCS Municipal General Hospital in Mumbai. He's been the organizing chair of Diabetes India in 2025, scientific coordinator for RSSDI 2023, so on and so forth. Currently, he's the elected All India Executive Committee member of RSSDI since 2022 and holds many other official positions as well. He's also well published and an associate editor for IJDDC as well as for International Journal of Clinical Metabolism and Diabetes. Without much ado, may I welcome Dr. Manoj to talk to us about CGM at therapy initiation.
Thank you, Purvi, and it's good to see you reading through a paper to introduce me. It's nice and very professional. Good evening, everyone, and welcome once again to the DTech Dialogues. We have our founder, Dr. Banshi Sabu, joining in. We had a wonderful conversation, and I thoroughly enjoyed Dr. Elaine's talk. And I must say, and then Purvi did the right thing by putting it that Manoj is going to have a very simple presentation, and that's exactly what I'm going to do. My topic is talking about CGM in therapy initiation, and that's exactly what I'm going to do with more cases and less theory. So over the next 15 minutes, let me talk on what I have to share before we let the experts get into the panel discussion to take up all the questions and discuss on technology and CGM further. Okay, I believe my slides are seen and in full screen mode now, Purvi?
Yes.
Yeah, thank you.
Yes. It's in presentation mode.
Okay, so let me start off quickly onto the topic, which is therapy initiation. And I'm not speaking only for drug-naive patients, but I'm trying to show different situations of different therapies when initiated, how CGM can be an ally to every clinician today to monitor, not only to the clinician, but also largely to the patient who may have reservations on therapy initiation of different kinds and in different situations. So we start off with what the ADA says in its standards of care in 2025, clearly recommends real-time CGM or intermittently scanned CGM for diabetes management to both youth and adults with diabetes on any type of insulin therapy. It also says consider using real-time CGM and or intermittent scan CGM in adults with type 2 diabetes treated with glucose-lowering medications other than insulin. So your sulfonylurea, glinides, or any other medication which can cause hypoglycemia should be preferred. In people with diabetes on insulin therapy, they should be used as closely to daily as possible. Of course, in a self-pay market like India, we've come out with our own recommendations, and I'll show about it as to depending on the ideal care or limited care settings, what is the recommendation that we have. It also says CGM can help achieve goals and A1C, both you're talking about time in range and A1C in type 1 diabetes and pregnancy itself. And also in circumstances where consistent use of CGM is not feasible, consider periodic use. So that's important coming from ADA itself, where they talk about the kind of intermittent use of CGM. So this is the RSSDI expert consensus for optimal glucose monitoring, which was published a year and a half back. And I was happy to be part of the author block with some of the other authors in today's expert group. And in this document, we did say that the recommended frequency of assessing CGM or TIR could be twice a year. Now, one would say why we are saying that it should be more frequent, but let's understand where we are currently of its use in India and hence even twice a year as an average frequency would be wonderful. But this was for patients who were doing a TIR of more than 90%. Should be repeated once in 3 months and more frequently once in 2 months for those with a TIR of more than 70% and TIR of more than 50%. So again, in those two categories, we wanted more frequent. We're saying use of clinical judgment or more frequent CGM for those who are experiencing hypoglycemia or on any of the drugs which warrant closer monitoring. The frequency can be minimized for patients with desirable TIR and with no or minimal time below range. Of course, treating physicians can take individualized clinical decisions on a case-to-case basis. So these are the two recommendations I wanted to touch upon before I get into the different case scenarios. My case number 1 today is a 40-year-old male diagnosed with diabetes 2 years, 1.5 years back, presenting with high sugar levels, was drug naive for managing with diabetes, so far managing the diabetes with diet and lifestyle. Intermittent scan CGM was recommended at the initiation of therapy to evaluate the glycemic profile. So this was one of those individuals who was extremely skeptical of starting therapy. For a year and a half, had somehow managed with lifestyle, but now the A1C had gradually creeped up to 7.6. Also, somewhere in the early days, patient was prescribed some therapy, I would believe a sulfonylurea combination, where patient did experience hypoglycemia and lived with that fear. This time when we initiated therapy, was extremely worried that I have had hypos in the past. I give me time, I'll still do that. This guy was 2 years down the history, 7.6. We said, no, let's start a DPP-4 metformin, a non-hypoglycemic FDC, but let's do a CGM for you to learn more about your pattern and, of course, to overcome the fear of hypoglycemia. And this is the report that we saw. This is again a recent one. As you can see, the AGP is from 6th August to 19th. So we picked up all recent cases as far as possible. What we see for this individual is a TIR of 98%. GMI, I think we will not give it much importance, which is showing a 6.2. But we can see a flatter profile. This individual is responding well to start off that 2-drug FDC with no hypoglycemia, which has been reported. This reassures the patient about the lack of hypoglycemia. Also, over the last 2-week period, the patient has been able to track what different aspects of food or lifestyle have pushed up the sugars intermittently. Even though we are seeing a TIR which is as good as 98%, there have been some spikes going above 140 for this individual. And again, we've changed this from 70 to 180 to 70 to 140 in an individual who's still young and more recent diabetic, who's extremely keen to probably get off medication, to get into remission. For such individuals, it may always be better to look at time in tight range to still be able to clearly pick up these surges above 140, which will make it easier for them to avoid those kind of food choices as rather than looking at 70 to 180. So this is one of the tools that we feel helps more for people who are extremely keen to improve their lifestyle and achieve remission and get off the medications if possible. I move to another case scenario, 81-year-old male, 15-year history of diabetes, hypertension, IHD, and early CKD. A1C remained high over the past year. Despite the suboptimal glycemic control, patient and family were reluctant to initiate insulin at this stage and still wanted to push it. The GFR did allow the use of metformin up to 1,000, so we continued. So the patient was on glimepiride, metformin, and voglibose. We said, fine, insulin would be ideal. Patient was reluctant, and as a patient and family, so we said, okay, let's change the orals and let the patient get on to CGM to try and improve on the control and see how it works. So we changed to a glycoside extended release and metformin combination, got in an empalina combination here again. And then let's see what is happening. So the CGM that we did for such an individual showed that the patient's TIR in the initial period was only 12.4%. 15-year history of diabetes, switching from one OHA combination to another really didn't help us much. But this aspect of looking at the CGM did land up convincing the patient and the family that, yes, in spite of their best efforts and change in OHA, the sugars were going high. The creatine was borderline high, and that was the factor that we really need to control better to avoid worsening of creatine. At this stage, they were convinced that they could start insulin. We started with 10 units of DTEK was added to the patient, and we said, let's continue the CGM because we are initiating another therapy, especially insulin, and let's see how this is helping. So the follow-up CGM report, well, did improve the time spent in range from just 12.4% earlier to 77.3%. Better control from the patient, and that little dose of insulin in this patient with diabetes, IHD, CKD made a huge difference. CGM here, of course, insulin did the job, but CGM along with insulin very often works in improving the patient's adherence to therapy, gets more reason to continue insulin and to adhere to a better food and lifestyle choice. And which is where for such an individual, this was extremely satisfying to see the improvement. So the visible improvement in the profile within a 15-day period is also a motivation to continue insulin. Otherwise, very often people after the first few weeks want to stop it because they're not able to see the difference or feel the difference, and waiting for 3 months or an A1C may not always they may not be that patient always to wait and continue insulin. So this again we feel has worked as a great tool. This is the ambulate AGP profile for this patient. After the TIR improved, we can see the overall profile getting better. Still some work to be done with continuous dosage titration and monitoring of the patient's lifestyle. We look at another case. 32-year-old female with diabetes and hypothyroidism visited the clinic for preconception planning. The HbA1c, this is 2021, was 7.6. Patient, when they visited us, was on she was on multiple OHAs. Of course, was now looking at getting into the preconception planning and getting into better control. So was advised to stop all those OHAs except metformin and move to the basal bolus regimen. We were still using a lot more pro at that time. This was 2021. A pro was recommended. So this is therapy initiation where you're starting insulin for a patient, and especially the one who's planning to get into better control for pregnancy. Well, the CGM report was reviewed. She did not report any hypoglycemic symptoms, but the AGP did show there were dips when the lunch was delayed. So we can appreciate here at around 1 o'clock the dip in the sugars. Also at night time, we can see that the sugars were dropping. Now, when we started that particular dose of insulin, which was 666 of aspartame and 14 of degludec, it was based on calculations of her body weight, her earlier OHA, and so on. But very often our calculations may go wrong, and which is where CGM again helped us picking up the hypoglycemia and titrating the dose to keep her under better control and avoid hypoglycemia. So this is her daily profile, which we saw, and clearly picked up the multiple episodes of hypo both in the nocturnal and the daytime period, and that allowed us to reduce the dose. Of course, the problem was that we could see this only after the period was over. So this used to be still the blinded and the professional CGM. So we reviewed it at the end of 2 weeks and then made the changes. Today, of course, with the use of real-time CGM, the patient can see the lows and immediately inform the clinic. And in the connected care environment, we can see and guide them. We move to another case of a 44-year-old businessman, diabetes for 10 years, visiting us for uncontrolled diabetes in 2022. Again, a busy lifestyle, not very regular with medications. Gradually, the dosage has been stepped up, but patient's been irregular on multiple OHA combinations as well as glargine. Yet the A1C was 13.6%. We recommended to start using GLP as this patient also had a weight problem. We did continue with the OHAs, cut down on the stop the DPP4 and started dulaglutide. This is Jan 23, which is when dulaglutide was the one which we were using more. We said, let's monitor it. Patient's A1C did improve to 7.8%. The weight loss was minimal. Patient was motivated to do better, came down only to metformin and dulaglutide. And then the patient was lost to follow-up, came up to us last year with again the A1C having gone up. As patient had himself self-titrated in the past, this time again he came with a history of having restarted insulin, glargine, stepping up the OHA, reintroducing glycoside, and so on. Patient's A1C was 9.4. At this time, tirzepatide was at least available in an access in the grey market in Mumbai. And patient said he had heard about it and had access and would be able to get it, and was started on tirzepatide. We continued the patient's glargine and the glycoside, metformin, voclibose. Now, this is February 24. If we had to do that today, I would drop down the dose of both sulfonylurea and glargine drastically. But way back that time, we didn't have enough knowledge into this aspect, and the A1C was 9.4. So we said, okay, let's start the GLP and we'll titrate. Soon after starting, in the first and second dosages itself of tirzepatide, patients started tracking hypoglycemia. Of course, this was real-time CGM. Patient could see that and was well versed with down titrating the dose and, of course, communicating with us. The patient down titrated, gradually got off insulin and all the OHAs, and was maintaining great control only on this dual peptide. This is April 24. The percentage in target only on tirzepatide is 97%. And this, I thought, is an important case because with the more prevalent use of the once weekly GLPs and the dual peptides, we are going to see a lot of response in this manner, where you will have to down titrate the other medications and to avoid hypoglycemia and monitor and guide the patients. So which is where every time you are initiating any of these more potent and efficacious drugs, it will be extremely helpful to monitor with CGM, which is going to be a clincher for good titration and downsizing the other medications. So last we saw the patient was in December 24 on tirzepatide 12.5 milligram. Hopefully when he sees me next, he's still doing well and there's not a yo-yo when he has stopped everything and gained weight and let the sugars go up. But the last time we saw him, he was doing super both on the sugar and the weight front. 59-year-old male with type 2 diabetes, since 13 years, presents with follow-up after 4 years with elevated glucose levels, A1C 9.9. This is case number 4. Again, recent, as you can see, 9.9 is the A1C on 25th of July. Patient is on this triple TDS dose of glimepiride metformin. We said, okay, we will change. Let's rationalize the use of the OHAs, but recommended the use of CGM. So again, this is an example of using CGM when you're switching or initiating a different regimen of OHAs. And what we see for this individual, and what I want to show in this case is this is a case till yesterday. Now, when we have seen this patient CGM profile, one, of course, all of you can appreciate that this person is not scanning late in the night or early in the morning, and hence the gap is more than 8 hours, which is still a limitation of the Libre 1. Of course, we have the Libre 2 Plus available now to use, but this patient was losing the gap. What's more important is you see the target range is 57%. So you made the change for this patient. If I am to look at just the AGP, I will see that the target range is 57. Everything looks higher in control. The reason I'm bringing this case to attention is when you start seeing the CGM, when you have changed the therapy, extremely important to get into the single daily profiles. Because for such individuals, the AGP will not give you the right picture, but the daily profile will. So track what is happening when we made this change on 5th of August till now. So you're tracking each day and you're seeing in the first few days, when the patient switched the therapy, the sugars were still spiking high and you see a lot of 300s. But as you start seeing the reading still the last few days, you start seeing an improvement, which is also evident from the average glucose per day, which was in the 300s and 200s in the initial days, coming down to the 190s. And the last few days are more in the 140, 150 segment, which means if I was to see the AGP and make a treatment decision and get more aggressive, it may be wrong. So for such an individual where you're looking at CGM during therapy change or different therapy initiation, do get into the daily sugar profiles to be able to guide better. And our decision for this individual for any titration should be based on the last few days sugar profile or tracing. And for such an individual, I would not make further change. He's already improved, would give time till I see with further reports and an A1C maybe 6 weeks later. So let me wind off by saying that some of the secrets of time effective use in the CGM in the clinic is make sure that the person with diabetes knows how to use the sensor and phone and has access to support material that includes the multiple time scanning and the different times. Make sure the person with diabetes, of course, can stay connected with you, knows your clinic code, whichever CGM you're using. Just looking at a CGM profile when somebody sends it to you is not important. So history, like in any other disease management, is extremely important when you're looking at a CGM profile. And hence, don't only look at the AGP, but look at the daily tracings and you learn much more to be able to help your patient. View the data with a structured approach, just like structured SMBG, you need to have a structured approach for CGM as well. Also, try to recommend one change. Don't look at too many therapeutic changes. One change at a time is what is going to get you the results better to get your patients more into target. And of course, plan and review the process if it's going to be more on the connected care system. So with that, I thank you all for having me. I thank the founders for allowing me to speak on one of the topics I'm passionate about. And thank Purvi for taking this initiative and doing the DTech Dialogues. Thank you so much. I'm open to questions. It's late in Mumbai also, Purvi. And if you will let me go before the panel discussion start, I am happy to answer the questions as well.
No, I think as a founding member, you cannot leave, but thank you for this very interesting talk with all the lovely examples you quoted. I think it made sense to use CGM in every single case, and I could see the difference. Having said that, I want to ask you a different question. Do people get distressed using CGM?
I think which is what the idea was in showing the last one, though it was not a complete instruction. I think it's important today understanding the limitations of CGM and the differences of interstitial fluid glucose and the differences between that and blood glucose. It's important for the patients as well as your clinic staff that all of us need to have a certain set of disclaimers when you're introducing CGM for patients, in terms of letting them be aware about the differences, letting them know that there are going to be times that there may be false lows and false highs, letting them understand the trends so that people do not start getting worried and start pinging your clinic and your staff or you all the time when they see certain reports. Also, CGM or any monitoring is an ally and a guide to the patient. It is supposed to help them. But an individual who's getting stressed, and there would be people who would tell you, no, I don't want to do this because I used it once or twice, but then I get extremely worried and I see anything I'm eating, the sugars are going up. If somebody is talking to you and telling you clearly that this aspect is stressing them up, you are either going to counsel them, but if it worries them too much, you may have to take a back seat. So really, CGM fatigue and CGM stress is an aspect that we are dealing with, and that's going to be a challenge as the usage increase, and the onus is going to be on physicians to tackle that. Which is where we will make a difference as trained clinicians and doing that, as compared to people picking this up from the market and just using it without understanding the technology. The last thing we want to see it happen is what happened to the SMBG. There was a phase where the glucose meters were sold directly from the retail chemist sections, where people didn't use it properly, thought that it was errors, they're wasting strips, or these are wrong readings, and it went into complete disbelief of the monitoring system. So hence, it's important that you do some hand-holding, have some clear guidelines and recommendations about what the patient should understand and expect from the CGM and when not to panic.
I think that was very well described. We have Dr. Banshi sir also with us, and let me just bounce this question to him as well. I think it's just, I'm intrigued. What are you seeing in the clinic? Because sometimes, it can be overwhelming to receive the very high number of snapshots or, data sets from patients themselves when they panic and, give you different time sets. At this time my sugar was so much, then this happened, then that happened, and it's just too overwhelming as a clinician. So what is your experience?
So this is very, very true. And particularly like just, before some time, I was seeing this report. I'm sorry, you will not able to see it properly because of this blur. So patient was on steroid, started by a skin specialist for a patient of CRF having uh, pruritus, and started with a steroid, low dose steroid. And suddenly one day sugar is increasing post lunch too much, sometimes post breakfast, sometimes post dinner, trying to give him already multiple times short acting insulin analog is going on, and patient keeps on asking, messaging, calling. So these are the challenges which we see very often. The other challenge which I am seeing, and when I ask my other colleagues why they don't use so often the continuous glucose monitoring, and one of the very common practical answer by them, I mean, it is good for a clinician to adjust the dose, and he will be very happy that I am doing and I am getting best results for my patient, even though it's taking a lot of time. But from doctor's perspective, sometimes they feel that what we get out of it, putting a patient on a 5,000 rupees a sensor, patient feel that, doctors have had charged me 5,000 rupees for this. It means now everything had come. He even does not want to give any consultation fees because he's coming in 5 days or 7 days or 10 days or 15 days. So we have to explain for that also, that where you are important, why you should charge for it. It is not just this 5,000 rupees is only charged for your sensor. What I am educating you, teaching you, or in between taking call, and all these things are really very important, and we should charge for them. For in-hospital hyperglycemia, other than who are admitted not in ICU, for some time we use it. There also multiple times call, multiple readings, keep on they sending us the medical officers, the doctors, and you have to just keep on saying about the correction dose or insulin or adjusting their diet. So it's really too much for a clinician sometimes, because you are already busy seeing so many patients. So you have like 10 or 20 patients of your who are on continuous glucose monitoring at any given point of time, and you just keep on seeing the readings and keep on answering there. But you feel very happy because you are getting the best results out. So if you know how you get, satisfaction, job satisfaction, that's also more important. But yes, one challenge is for many of the clinicians that they don't want to put the patients on CGM because they are not ready to take so many calls or not ready to take so many reports, and changing the therapy multiple times. That's really difficult. It's like becoming an intensive diabetologist. Like there is an intensivist in the same way. You become an intensivist for them. Sugar control.
So I would call this technology inertia.
Yes, there's a technology inertia by many of the doctors. The other reason for technology inertia, which I always say, in some of the postgraduate institutes, not even those who are running medicine, internal medicine department, those who are trained in internal medicine, they are never exposed with these technology. But even some of the super specialty hospitals, some of them, or 99% of the super specialists from where they get trained, even there hardly any experience of using continuous glucose monitoring or insulin pump. It's like that someone is doing his master MCH in gastrosurgery and no experience of laparoscopy, or someone who is getting his DM cardiology without any experience of angiography. The same way, those who are getting their DM degree in endocrinology and no experience of this newer technology. I mean, this is what is happening in our country, and that's the reason why usage of the technology is really poor, because one guy who is very expert, like suppose Mithun is doing for a lot of his patients, asking them to do for CGM, for pump and all these things. And next door to him, he may be again a consultant having a similar degree, but he is not exposed, and he may say, no, it is not required. So it creates more confusion for the patient.
Got it. Very well said, sir. And with that, I think we can just move on to the panel discussion. And we are very lucky, fortunate today. It's a really special panel because we have the DTech Founders Group here. And I thank each of them in all their busy work. They have managed to come here today for and illness. They've still managed to show up for DTech Dialogues. So really grateful for that. I now welcome Dr. Jyoti Dev sir, who is a senior diabetologist and consultant physician from Trivandrum. And who doesn't know him in the world of diabetes, obesity, as well as technology? Without much ado, sir, please, the panel is all yours. And we have Dr. Banshi Sabu sir as well, Dr. Manoj Chawla, Dr. Mithun Bhartiya, who is a senior diabetologist and consultant from Guwahati and a founding member of DTech. We also have Dr. Amit Gupta here, a founding member of DTech, and he wears multiple hats, internationally as well as nationally. And he's from Greater Noida. So welcome, Amit. And we have Dr. Rakesh Parekh. He was just here, and yes, he's right there. He hosted all of us at DTechCon 2025, senior consultant diabetologist from the city of Jaipur, and a founding member of DTech. Very passionate about technology and has many other facets to him as well. So here is the panel for you, sir. Please quiz them.
First of all, thanks to Puri for giving me this opportunity. And this is a rare opportunity because Purvi has brought all the DTech founders together. And we are all together to discuss about both the basics and advances in continuous glucose monitoring. So I will continue with what Dr. Benshi said. Dr. Benshi, in response to Purvi's question, was answering on the difficulties responding to the many questions of patients. So when we are advising our patients on continuous glucose monitoring, many a time they keep on asking, they keep on questioning us, and for every glucose high and low, for every reason, they will keep on asking us. And this happens during the day, this happens during the night, and many a time we find it very difficult. So my question, I will go by the alphabetic order. So is there any solution? Amit Gupta, is there any solution to overcome this? This overwhelming after initiation of continuous glucose monitoring, especially when you are having more than 50 or 60 patients on CGM and many of them trying to contact you, how will you resolve this? Amit?
Sir, I think Dr. Manoj Chawla, yes. Thank you, Dr. Jyoti sir, for joining me. If you are not DPL, we can know. But this is dedication to diabetes technology and the tech brings you here. So, to answer the question, nowadays patients are using the sensor and we get the live data. I think it's
Manoj,
very
Amit,
to the
your
patient,
voice
right?
is blurred.
Yeah, Amit, your voice is breaking. Can you switch off the video? I think that will be better.
Come down. Close your video and then you can speak. The bandwidth will come down.
Or just come closer to the mic. We can hear you.
No. It is he's actually traveling and the range is poor, I believe.
Is it fine now? Is it?
Yes, better.
Yes, okay.
Yeah,
So,
please. Yeah.
I would like to mention that thank you, Dr. Jyoti Dev sir, for asking that question and joining today despite not keeping well. And this shows your dedication for the DTech and your commitment to DTech as president of the DTech. So I would just like to tell now we are using a lot of CGM devices and the data is shared with us on different platforms. For Libre, we are getting the Libre view, and the other CGM sensors, they also have the platform. So the solution to the problem lies in the patient education, which Dr. Manoj Chawla rightly pointed at the beginning, that if you provide the supporting educational material to the patient, tell them what is expected from this CGM, explain to them that why the readings, there may be difference between the readings, why there can be, sometimes the CGM readings may be higher than the capillary glucose reading, sometimes there may be lower than the capillary glucose reading. So help educating the patient is the key to successful use of CGM in the clinics. So I think it is not just the doctor's education, but also the patient education. And clearly telling that you're not watching the data live. So it is very, very important that you mentioned that patient that yes, you are using a CGM, but we are not having this data is not monitored live and we are not having any mechanism to monitor this data live. So only when you are going to initiate an consultation or initiate a discussion, only then I will go back and look at the data. So I think this should be mentioned to the patient very clearly. And once you tell that, then most of the patients, they are able to understand that this is not, and the expectation level is realistic and not overwhelming. So.
Yeah, I think that answer is very meaningful, a very realistic answer. But in addition, I will make a suggestion that, of course, training the patients are good. You can give education brochures, but more important will be probably, if you all of you agree, training our own diabetes educators and nurses. So we need to train them, and then we need to make sure that our staff working with us are capable and knowledgeable enough to answer to most of these questions. And when newer drugs are being launched, it can be tirzepatide, as Dr. Manoj said, or it can be older drug, how to adjust the dosages of drugs. So all of these need to be probably trained to our diabetes educators and nurses. So next question is to Dr. Midhan. So Midhan, you have been listening to the lecture on chronic kidney disease. And we know that in chronic kidney disease, it is probably important to have glucose monitoring. And even the glucose meters can be wrong. Some of the older generation glucose meters can give wrong reports. And our objective using a CGM is to have a TAR not more than 70%, but the idea is to have only more than 50%, and that is only to prevent a hyperglycemia. So if you are recommending continuous glucose monitoring to those with advanced chronic kidney disease, what advice will you give them?
So I think there are two challenges. I think, thank you, Jyoti, for this question. See, one point is, if we have to give it to an advanced kidney disease, better to give somebody who is well hydrated. So in an OPD setting, we can still consider it. In an IPD setting, the matter becomes very, very gray because there's a lag and other problems with, the intestine, the fluid content is very up and down. So in an OPD setting, we can use it, but it has to be taken with a pinch of salt, because the general tendency of the patient is, the nephrology, you will go to the nephrologist and the nephrologist will say, what is this? So have your nephrologist on your side, because if it's an advanced kidney disease, he is with a nephrologist.
Yeah.
The buy-in from the nephrologist is the most important game here. Once the nephrologist says buy-in, the life becomes far more easy, because the person will listen to the nephrology. Whatever the nephrologist says, if he says get up, he'll get up. If he says sit down, he will sit down. So once the nephrologist says buy-in, all the factors becomes much, much more easier to buy in. But the problem will happen is that some people will obviously check the glucose. It's like when we started using the CGMS, even us, there was a discrepancy and people get worried. So I think that has to be overcome. And the initial challenge which I felt was, patients, if you are on a dialysis or something like that, the sugar, they give fixed doses of acrapid and fixed doses of novorapid. And that will come as a big bolt out of the blue, because you're increasing the workload of nephrologists, or increasing, their modus of operandum. But definitely use. So I use it in a OPD setting when the paired glucose readings are not making sense. When I'm with the symptoms that the patient is saying, and I'm not being able to do it, use an ISO 2000, latest ISO 2000 glucometer. But still there are variability, and I tell them there are 15% variability, and the same variability will happen with the CGMS. So it will give you a rough idea that we are sitting in, we are coming to Mumbai in Manoj's conferences in the posh Geo Convention Center, but where in the Geo Convention Center, we may not know. So that, that education is very important.
Excellent answer. And these are some of the gaps in practice. Because I was going through the literature, and it says that the MARD of a CGM in advanced chronic kidney disease can be as high as 15%. And the current MARD of so many devices, it is less than 10%. So CGM is less accurate, but still with some education, for example, when to use a glucometer and when not to use a glucometer, because at times of dialysis, probably you have to rely more on a, as you said, a branded glucometer, but other times probably sometimes the CGM will be accurate. So Yeah, thank you, Midin. Among the DTech founders, you are the real professor of endocrinology, Dr. Midin, a very knowledgeable person and directly trained by those founders of real founders of Syria. Raghav Mase. Thank you. And next, my question is to my dear friend Rakesh Parik. Rakesh Parik works not only with doctors, but also with the community, with the society, a very dedicated individual. And the question is, despite more than 100 million people with diabetes in the country, not even 1% of them are using continuous glucose monitoring devices. And Dr. Benshifai made a comment, and that comment is actually a very relevant one. In the MBBS curriculum, in the MD curriculum, or in the super specialty curriculum, whatever be the specialty, some of these key elements in prevention is not discussed. So, in your opinion, how can we change this scenario, which is so important because our focus is only treatment of complications, not in the prevention of complications. Yeah.
So thank you for asking the question, sir. And it's the fact that overall the usage of technology, specifically CGM and AIDs, is very poor in India. And in that also we have got a lot of regional variation. So there are states like northern states, Rajasthan, you would have very poor users of CGM or any other technology. There might be better adoption in states like Kerala. Now, I don't know whether it's a difference between the societies there or the KOLs there. Maybe the people in Kerala are lucky to have Dr. Jyotidev, who has been, the torch bearer for technology and creating awareness among people, and that is why the usage has increased there. The second aspect is about affordability. So it's not just financial affordability, but even psychologically, there are differences in what people are willing to spend on healthcare. So in Rajasthan, they might spend on parties, but not on the healthcare. So that variation is there. I think to answer your question, what is the key to address this? We need to fight it on both the fronts. One, to create awareness among the HCPs and also among the public, because the public is not very much open to spend money on technology. The doctors in some parts, like in Rajasthan, they shy from discussing these options with the patients. They feel that if I tell the patients about technology, I might lose the patient. So that is also one inertia that the doctors have. So I think we need to address this at both the ends, educating the HCPs as well as the general public.
I think that's a very valid point. If you discuss about expensive technologies, you might lose the patient. So that is a fear, and that is justifiable also.
Right.
Because all of us probably could have experienced the same. Because when we are suggesting an expensive medicine or expensive technology, the first thought the patient is having is it really required? And is it for some other reason the doctor is suggesting?
Yeah.
So every time we are actually having this sort of a discussion, it makes sense that you should be spending more time.
Right.
And that quality time probably will decide on. So is Amit Gupta there? Amit Gupta, have you reached home?
Yeah, but is here.
Sir, you can change the sequence. You can ask Mithun first and then Rakesh and then take me. By that time, I will be at home.
Okay, wonderful. Okay, so Mithun, imagine a situation. These are random questions. Imagine a situation where the cost of a CGM sensor, which is currently around 5,000 rupees, all the sensors put together, 5,000 rupees, it is brought down to 10,000, just 1,000 rupees a sensor. And in that scenario, do you think that there will be more people using it, or will it remain the same?
So I think I'll put historical answer to that.
Yeah.
All remember when Libre Pro was there, it was priced something between 2,700. And it was a huge task for people to start using it 2,700. Obviously 6 years ago, 2,700 is worth 5,000 now with the inflation. But at that time, 2,500, 2,600, because this was a new thing. I think the biggest flaw at that time they should have priced it lower and gradually increased it as the usage went up. Now the sudden move from 3,000 to 6,000 obviously is a huge change, and there has been some people cannot afford it. But the noise has gone up now with competition coming. Now Sinocare is there, Libre has been forced to bring their 2.0 plus, and some more CGMs will come. Price of 1,000 You mark my words, HbA1c will become a forgotten entity in 2 years' time. If the price comes down to 1,000, HbA1c will be a forgotten entity in India. It's my 100% prediction for the future, and it will come down in 3 years' time, and HbA1c will be stopped using. Then the actual CGM use will come.
Okay, fantastic. Rakesh, in continuation, it is not that easy to use a sensor when compared to A1C, because A1C you can measure in the lab. But CGM, you cannot properly administer or deploy CGM in all the patients. It is not practically a possibility, even though it is available at a low cost, or even though it is available completely free of cost. You have to choose a person for the use of a technology. So, do you disagree with Mithun, or do you agree?
No, I agree with Mithun as well as what you said. Basically, as Manoj had also presented in his presentation, there are certain set of patients where we should use CGM. The patients who are on insulin, patient who are on glucose lowering therapy, somebody who is a pre-diabetic, it might be just for making some behavioral change. Somebody who is on drug like metformin or a GLP, again, it might be just for making some changes in their diet or lifestyle, but it doesn't help them much. But people who are on glucose lowering therapies, whether it's OHA or insulin, will better use CGM. And right now, we are not able to use among those people also because of the affordability issue. So I think Mithun is very absolutely right. If the prices come down to what you said, definitely the usage will be multifold, and it would be more in these people where it is indicated.
Okay.
Sir, I would like to add one point to what Rakesh just said.
Yeah.
The cost and affordability will always be a question whenever we are talking about the use of CGM in a country like India and in any developing part of the world. But when we are using these technology, one has to remember about the long-term cost of the CGM also, uh, long-term benefits of good glycemic control. So there are many studies which have shown that if we are using CGM for a continuously, or when the patients that get benefit, then definitely there is a reduction in the need for hospitalization. There is a reduced cost which is incurred over a long period of time for the management of the complications. So the affordability question can definitely, immediate affordability can be a question, but when we explain to our patient, for example, Dr. Manoj has shown very well that if you put somebody on a drug like tirzepatide, and if the patient is already on multiple daily insulins and all, and you are using a CGM, you can see that the graph is settling, the insulin requirements are coming down, and with the weight loss, sometimes these patients may be even of drugs. But you can do all this only with the help of monitoring. Without monitoring, even you will be scared to put these patients on drug like tirzepatide or semaglutide or the Wegovy, something like that. So I believe it is a long-term cost analysis should also be considered by our physician colleagues and friends. And one should not discard it as an expensive technology simply because the immediate cost is onboarding cost is on the higher side.
Okay. Amit, have you reached home? Can you switch on the video, or because your voice is now very clear?
Sir, just 10 seconds.
Jyoti, I can take a question if there's something for me.
Okay. I forgot you. Okay. Sir, I just wanted to add one point to, or continue from where Amit left. So he's absolutely right. If we spend more time and explain the patient about the long-term cost effectiveness of CGM, we might be able to convince more people. And that is what you also said, that we need to spend more time with people. Now I'll give you a different concept here. The cost effectiveness of the doctor's time. So the problem is that the doctor who is paid 300, 400 rupees for a consultation, he doesn't spend half an hour with the patient. He feels that that's not cost effective for me to spend half an hour convincing a patient to take a CGM. And that is why the doctors in my part of the country, they don't spend much time in convincing patient. They will tell the patient it's an option available. If you want to go for it, go for it. Because the patients, first you need to convince them about the long-term benefits of CGM use, and secondly you need to address their misconceptions or their thoughts in their mind that the doctor has got some vested interest in prescribing CGM. So many things are there. So I agree with both of you. if we can afford to give more time to patient, probably we'll be able to convince more patients. What would help more is the awareness among public at a mass level. So through the television, through the media, through the print media, if there is a awareness about CGM uses created among the public, probably they will be more willing to take it from our advice, right?
Yeah. I have another meeting to start. So, Amit, I have a question to you. Yeah, you are an international person. You are attached to ADA, IDF, and so many organizations, and you are also leading some of the clinical trials where some smart watches are also tested for glucose monitor. And we, the DTech founders, we are pretty much aware of this upcoming technology. Sooner or later, it will come.
Yes.
And how disruptive it is going to be.
I think, sir, it is going to be a big change in the space of glucose monitoring because you will be having one more option available to you. Of course, it will also come with its own set of challenges. So again, there will be some limitations. There will be differences in the capillary glucose readings and the reading shown by the smart watches or the devices. So I think 100% accuracy is still because we are talking about a MARD of 15%, and we don't know at what mark these devices will come. So I think the technology will may not be disruptive immediately, but it will definitely assist all of us in better glucose monitoring.
So you don't probably expect this to come very soon. It might take another minimum 5 years.
I agree with you because people have been trying to build around this concept for almost 2 decades, you can say that. But with very little success because there are challenges which comes with the monitoring of the glucose non-invasively. But I think a lot of development and a lot of advancements and the people, the newer with the advent of the AI. So the AI is definitely going to play a big role whenever this non-invasive glucose monitoring is come to play. So now the newer trials and newer algorithms, they are probably testing the AI built component as well with this kind of monitoring.
Thank you very much. So shall we have a last round? And this is going to be a take-home message, starting with the Midhan. And this should be a message for the doctors who are practicing diabetes. And this should be a message on continuous glucose monitoring, how important it is. And it should be a brief message from all of you. And then I will pass on to, and I will request Manoj and Benshi also to have a brief message if you are there. And then Purvi to sum it up. Thank you very much. We start with Madhu.
I don't know what I was practicing diabetes before I started using CG. God bless the patient.
Rakesh?
Yeah, for doctors, I would say that CGM is a very useful and effective tool to better monitor your patients and achieve better results and long-term outcomes also. So be open to it, try to learn it, and try to use it in more and more patients.
Fantastic. Yeah. Amit, yeah. Unmute.
Yes.
Yeah.
I would like to mention that, sir, now there are many initiatives, like right from the DTech, from the RSSDI, we have now the CGM programs coming from the RSSDI. So participate in as many programs as possible. Try to learn the CGM as Rakesh has pointed out. And do not shut yourself completely from the technology. Don't believe that this is not my cup of tea. I'm not never going to use CGM. Do give it a try. You will find if you see 100 patients, you will find even 2, 3, 4 who may be willing to use the CGM. So please don't shut off yourself completely from the use of the technology. Try to adopt it.
Wonderful. May I ask Manoj, take home message from you?
I finally get a chance.
Yeah, you finally got a chance.
Final last.
Well, I think, gone are the days that we should think that CGM is meant for a select few, both in terms of, it's only for the tech savvy or the users of technology who can use this. It is today a household name. for people with diabetes and, of course, people practicing the medicine of diabetes. So it's important that all of us update our own knowledge on more responsible use of CGM and also try and transform that knowledge to our patients to use it in the correct manner, understand what to expect and what are the limitations. And of course, in India, individualize the frequency of use to optimize its benefit and have the cost benefit ratio. So I think in moving ahead, use of different technologies as it comes in is important. We also are aware today that we are constantly asked this question about the new pulse oximeter type looking device available in the market. Is that good enough? Well, you will have a lot of different devices available in the market which are not validated, and hence all the more important that monitoring is extremely crucial to managing diabetes. To understand the responsible use of validated tools, the different um, uh, CGM available from different vendors in India, that is increasing. You will have more and more access. Hopefully, they get more and more affordable so that our patients can use it regularly and benefit from seeing their glucose profiles, which I think is the most important. I would just like to add that way back, Professor Elliot Jocelyn, considered the father of diabetology, had said, a person who knows the most for diabetes lives the longest. I think it's fair to say in today's time that a person who monitors the most shall live the longest when it comes to diabetes. So that's my take-home message to everyone who's joined in today. Thank you.
Okay. It was like Elia Johnson. Thank you. So great words of Manoj. Thank you very much. And I am so happy that I am also invited for this program, and we all the founders of DTech are together for this DTech dialogue. Thanks to Purvi. Back to Purvi. Thank you.
Thank you so much, sir. And I'm just in awe because I think this was a very complete webinar. We had CGM, but CGM, diverse uses of CGM. Today we discussed with an internationally acclaimed expert and all of you who are no less than that. And the DTech Founders Group, I think a very, very fascinating webinar. So if all those who missed it, I would recommend going back to the website, just log in using your user ID and password, and it's right there, saved there, and you can access it at any time. But do that because there were some very important learnings shared today. Thank you again, each of you, for sparing the time for DTech Dialogues and DTech and being here.
Purvi, let's not forget to invite them for the conference, DTech Con.
Yes, without we have almost 200 ambassadors of DTech, and they were all the ones who got the early registration. But we invite all of you. The registration is still open. Go ahead, do it, and we'll see if you're lucky. You still get to be a DTech ambassador.
Good night. Good night. Good night, everyone.
Thank you,
Good
Dr.
night.
Purvi,
Good night,
for
everyone.
hosting us. Thank you.
Bye. Good night, everyone.
Bye. Good night, everyone.
Thank you, Team USV, for again hosting this important endeavor of DTech and always being so proactive in everything that you do. Thank you so much.